Welcome to the Chalk Talk Gym podcast, where we explore insights into healthcare that help uncover new opportunities for growth and success. I'm your host, Jim Jordan. Welcome back to our podcast. In an ever-evolving landscape of healthcare, innovation is key to navigating complex challenges. And our guest today, Nkana, is a trailblazer advocating for physicians in the business of medicine. With unique background in law and hospital administration, Ethan founded Rocky Mountain Physician Agency to empower doctors in contract negotiations. As a former hospital executive, Ethan immediately understands the pressures physicians face, from burnout to lack of autonomy, and he recognizes that while doctors are exceptional at advocating for their patients, they often struggle to advocate for themselves. Ethan's on a mission to ensure doctors can focus on providing the best patient care without compromising their well-being or fair compensation. In this episode, we'll explore the shifting dynamics between physicians and private practices and hospital systems, and Ethan will share insights on physician contracts, the impending doctor shortage, and how his work is transforming the way physicians navigate their careers. So Ethan, welcome, and tell me and the audience a little bit more about yourself and what motivated you to become a physician advocate.
My name is Ethan. My last name is Nkana, Nkana. My journey is, I think, a little bit eclectic in the sense that I'm a lawyer by training, but I never practiced, and I never wanted to practice. I went to law school to get my law degree, to develop the skills to become a hospital CEO. And while all of my classmates were taking the bar, I was finishing my MBA at the University of Dayton. And I wanted all of that to lead into my career as a hospital CEO. Little did I know, in 2019, I was going to get laid off and really reevaluate what my career path is and what my career purpose is. Why am I doing what I'm doing? And it's led me now into this path of being a talent agent for doctors and advocating for doctors in contract negotiations.
So we were talking earlier, trying to understand, is that mostly private practice or people that are physician practices that are on. So maybe for the audience, share how physician practices work. Some are private, some are owned, just to give people some context.
Yeah, so you typically have kind of the major dichotomy between private practice and what you would call physician employment. Now, the hypocrisy in that is that you can be an employee in private practice, but for the sake of the discussion, we'll just say there's private practice and employed. Employed tends to mean large hospitals, health systems, or even community hospitals and clinics, where the doctor gets a biweekly or bi-monthly paycheck that they can rely on, no matter how busy they are, no matter how much work they do, how many hours they work, they get this consistent paycheck. In the private practice side, you see a lot more of an entrepreneurial spirit among doctors, and many doctors are paid on what I call what you heal model. So as busy as you are, that's how much earning potential you have as a physician. And so that tends to draw physicians who are interested in autonomy and earning potential. And at the same time, the business side of medicine, which frankly is daunting to many of the doctors I work with.
Have you noticed there's an age line there in that decision to be employed or not employed?
Ooh, interesting. I've never thought about it that way, Jim. But when I think about the doctors I serve, I can maybe think of one or two doctors who go into private practice directly from training. That is similar to being a lawyer, leaving law school and putting up your own shingle. That's kind of a lost art. You don't see that as much in the industry. So many doctors come out, go the employed route, work for a few years, realize it's a business, and then they decide, I want to change pace. I want to change direction. And maybe they decide to go the private practice route. So I do tend to see it more with experienced doctors as they get 5, 10, 15 years into their career. And they decide, I want to control how I practice medicine. I spent 15 years as a hospital executive, and I was telling doctors, you need to see patients faster. The budget can't support another medical assistant. All of these things that help doctors provide the best care, but yet people with MBAs are making those decisions. And that just is completely incongruous with the Hippocratic Oath. And so it should be doctors who are in charge of how long they need to spend with patients. What support clinically do I need to care for my patients, not MBAs and attorneys like myself.
I think too that one of the things that's interesting to me as someone who focuses on information systems is that I started my career in the manufacturing side, and I could tell you down to a half penny what something costs. And I could also tie that through cost basis analysis to revenue. And when I talk to my CFO friends in a hospital system, it's more of a cost bucket that they throw it into, and you can't see cause and effect. So, for example, when physician measurement first came out and I was involved in it, you would talk to the physicians who get what they call the train wreck cases and say, you can't be measuring my performance against someone who's getting the easier cases. And so it's a lot more complex than that. And the fact of the matter is the MBAs that you're talking about don't actually have the tools to be able to do what we would call activity-based costing, right? So you get laid off. What made you thought of doing what you're doing?
It really was an epiphany I had. And there's a magazine over my left shoulder. It's 5280 magazine. I framed that because about a week after I got laid off, I reached out to, she's now my wife. At the time, she was my girlfriend. And she said, hey, you're stressed, you're frustrated, you need to go get a massage. So as I'm sitting in the lobby waiting to go back for my massage, I see that magazine on the table there. And it got me thinking, do those doctors know how much they should be paid? How do doctors know how much they should be paid? And the thought that really catalyzed this idea was, why don't doctors have agents like professional athletes? They go through a decade and a half, 20 years of training, put their head in the sand to become elite at their craft. They come out, make all this money. Athletes hire agents, negotiate their deals, and doctors, I can tell you from experience, do it themselves. And they leave a tremendous amount of money on the table. And that really was the genesis of Rocky Mountain Physician Agency, which is a talent agency, not for musicians, movie stars, and athletes, but for physicians.
I love that. So how did you find your first client?
It was networking. Again, the only thing I've ever done in my career is work in hospitals. So I don't have any shortage of doctors in my Rolodex who I worked with or interacted with. And the initial clients were doctors in the same health system I had worked with as an employee who I knew were frustrated. And then I imagine you can probably relate to this as well. But once you help doctors, doctors talk to doctors. And when they realize, wow, Ethan has my best interest in mind. Ethan has unparalleled experience working in hospitals. He knows the business of hospitals. And Ethan isn't going to charge me like an attorney by the hour or by the 6-minute increment to talk to me. I've talked to 3 doctors today already, just on questions who are not clients, just on questions they have on situations they're going through. And so ultimately, my job, yes, is as an agent. That's fun and amazing. But I also see a big part of my job is as a teacher.
Oh, that's interesting. So when I go through contracts, I actually mind map them, right? So you have all the layers and how it all layers out. What are the triggers that you learned can help physicians?
The biggest thing that I think about is the patient. I am focused on how can I help my doctor be laser focused on the patient? And what are the barriers to that? I don't feel as though I do anything but work. I'm at the hospital or my practice all the time, or I don't feel as though I have agency in making decisions on behalf of my patients. One of my clients right now, for many doctors who are listening, you probably are accustomed to hearing 15-minute visits. Well, the practice that I'm talking with now, they've been asked for the last 6 months to put on a 10-minute visit. And these are OBGYNs, not any other specialties, they're OBGYNs. So they're somewhat like specialized in their work. And so my job is to support those physicians by advocating for those patients to get adequate time with the doctors.
So when you're dealing with the hospital administration, what gets them to make those changes? Is it the risk of losing a physician because we have a physician shortage coming up? Or is it, we were talking activity-based, are you connecting? For example, there's clear data that shows the decreased time a physician has, the lack of bedside manner, the increase in malpractice, right? And someone could not be as strongly skilled and be charming, and they have a better malpractice rate when in fact, maybe in real life, they should have a higher one.
Yeah.
So that data is there, right? So these are kind of things you bring to the attention of.
My work, it's almost color by number. So when I do education for residency programs, fellowships, physician associations, I give doctors the blueprint to go do this for themselves. You don't need to hire me to do it. I don't do magic. I follow a formula. So for these doctors, the very first thing that I do when a doctor hires me, and look, I'm going to say the hard part first, you must be willing to go. I'm not saying you have to go, but you must be willing to at least consider it. And here's why. I worked with a group of 6 women physicians, and they're all OBGYNs. They went to their employer, which is a national for-profit health system, and they said, we want to be paid fairly for our work. The employer predictably said, which I told the doctors, said, we can't pay you another dollar or else we're going to end up in prison because of Stark law violation. So I said, okay, here's how you fail. By going to your employer and asking for a salary raise. You will fail. I don't care if you're a neurosurgeon, family medicine, or anything in between, you will fail. The way that you give yourself the chance of success, and again, you will stay with your current employer, but you must go get a competing offer. You must. That is an essential and non-negotiable part of the process. So I went out and I got 3 offers for these amazing doctors. There were 6 of them. These offers were for more money, better schedules so they could spend time with their family, and more support in their practices. So obviously these doctors were going to go, right? It's not that simple. Doctors are not motivated by money, generally speaking. They're motivated by support for my patients. I want to have a seat at the table, a schedule that fulfills my cup. And so what we did was, after we got those offers, we came back to the employer and said, look, if you're not willing to advocate for these doctors to have adequate time with their patients and adequate support, they're going to go somewhere where they can. And then when I said, hey, they have an offer for this much more money, then the tone changes. Now, well, hold on, can we have a conversation? So the punchline to that is the doctors got everything they asked for. More support, more MAs, NPs, better schedules, didn't have to take as much call. Now there's a call pool of locums doctors ready to help back them up. But here's the kicker. Those doctors did not ask for a single dollar when they met with me. But as a result of working together, we got them $180,000 each, individual base salary increase. And then individually, we also got them a $40,000 bonus just to stay with their current employer and sign a new contract. So less than half of that went to paying my fee, because my fee is a percentage of my doctor's pay. So the doctors know exactly what I'm motivated by, and that's to help you make the most money.
Can you explain the Stark law to people just to make sure they understand it?
Yeah, there's kind of this pair of laws, Stark and anti-kickback, that usually tend to go hand in hand. The punchline is it is illegal to pay doctors for their services and referrals, or volume of services and referrals. So in the hospital world, the way that typically works is when you talk about a doctor's pay, you cannot in any way implicate volume. Well, if you send us this many patients, we'll pay you this much. That is considered illegal. And I think fundamentally part of the rationale is we want doctors to do what's in the best interest of the patient. And if there's a financial incentive, now there seems to be a conflict of interest potentially.
So as I understood that law, it was more about doctors being financially motivated to make referrals, to have the money come back in their own pockets. I think that is the simplest form of that law.
Exactly. Yeah, exactly.
And it got a little more complex because the law was intended, or it came about when most people were in private practice or wholly owned physician practices. And now that these practices are owned by hospital systems or integrated delivery networks, that law might be a little less clear on how to execute it, is my sense of it. Is that how you...
What I tend to see now is, and I did this when I was a hospital executive, but I just use it as a shield. Hey, doctor, I can't pay you any more money because it's starting into a kickback. Well, what does that mean? Don't worry about it. It's bad. It's really bad. So I never actually, even though I studied Stark and anti-kickback deeply when I was in law school, I never used it in the legal sense. I always used it in the business sense as a way to chill doctors from taking action, meaning going somewhere else.
There's an old saying, pinpoint, don't label, right? And label is so it seems to me they're using that law as a label that no one really has an agreement on the definition of it in its details. So when you're working with these physician groups, how are they finding you?
The biggest thing is education. Before anything else, I'm a teacher. I want doctors to know the challenges you're up against in the business of medicine. And if a doctor wants me to help give them all the answers to the test so they can do it on their own, awesome. But ultimately, most doctors find us as a result of residency education, fellowship education, physician associations. I was with National Medical Association a few weeks ago, and I'll be with the Iowa Association of Family Medicine Physicians here next month. Again, just helping doctors understand the challenges they're up against and how they can advocate for themselves and for their patients in their contracts.
So I think one of the things that's valuable about using someone like yourself is that change can happen without physicians having a confrontation with administration, right? There's two ways to go. We negotiate hard for ourselves and break down some relationships, or we don't negotiate hard for ourselves. And I guess you can play that role. So as you've grown, what challenges has your organization or you had in servicing your clients? What have you had to change or adapt to, or what do you see as changes that are coming?
I think the biggest thing that I found so discouraging is most doctors don't believe they deserve better. I had a doctor call me recently out of New York, she's a rheumatologist. She had her salary cut in half, her guaranteed salary. Now, from a hospital executive, from a mathematical perspective, that seems almost impossible. But it happened to her, and there were some reasons that she explained were valid at the time. The reason she called me was because the employer had not fulfilled their promise to make her whole after she took that cut. And so she hired me to help her resolve that cut in her salary. But the challenge is that doctor signed a contract in good faith to cut her salary in half. She didn't think to say, wait, how is this going to benefit me again? She didn't think she deserved better. She didn't think she deserved to advocate for herself. And I think that's the thing that I'm so deeply saddened by, is that more doctors don't believe that they deserve to be paid fairly for their work, sacrifice, and commitment.
I think the other piece is there's no place to go to get benchmarks on these numbers. Now, I just happen to know, I was showing you earlier, and for the audience on my website, Healthcare Data Center, instead of .com, it's .center. If you go and you type physician, you'll get some of this data. But I just happen to know from that report that rheumatologists are one of the poorest paid physician groups. And part of that reason is there is no chargeable CPT code. It's more a visit thing, and it's more an outcomes thing. And so even though we're trying to move to value-based and away from these individual codes, the fact of the matter is that physicians are still predominantly paid through CPT codes. So I think that's kind of interesting. So as you learn to negotiate and you've developed your techniques, what sort of shifts have you made in the past 4 years since you've been doing this for 5 years?
I realized that doctors don't care about money as much as I was hoping they would. So my messaging has changed from helping doctors maximize their compensation, which is where I started. Really, it was the same model as athletes. Make a bunch of money, be on the best team, and that's what makes athletes happy. But that's not what makes doctors happy. Doctors are motivated by their purpose. Doctors are motivated by the outcomes of their patients and relationships with their patients. And so I've shifted entirely my focus to be more intentional about time with patients, resources you need to do your job, feeling as though you're not stuck at work all the time. And then the third leg of the tripod is do deserve to be paid fairly. You don't have to make $1 million, but you deserve to be paid fairly.
Well, I think you know this, and maybe our audience is more than just physicians, so I'll share this. There's a lot of these physicians take that administration home at night and spend weekends on that stuff. And so recently, I just happened to be, doing my annual dermatologist visit, and I've had the same person for a million years, so we know their kids and all that kind of stuff. And so we were just chatting. And I said, "Oh, you actually have a scribe with you now." And she said, "As practice, we sat down and, we were all burning out and we were all taking away time from our families. And we realized that if we just added this incremental spend, how much productivity we could get, not only in terms of after work hours, but actually open up appointments in dermatology right now is very hard to get people, right? There's a shortage. We can actually create more access." And so I think that's interesting. So as these contracts are changing and policies are changing, where do you go to keep track of all these changes?
I love to stay. So right now, if you look at my inbox, I've got some fierce healthcare updates, some Medscape updates. So again, I am going to nerd out on your website because a lot of the things that you highlighted in that report, a lot of things we didn't even look at, but things like burnout, that is a growing concern for doctors. The impending physician shortage are things I think about. I also am looking at trends in physician pay around gender, race, things like that. So I am always interested in kind of the cutting edge of, I don't so much care about the legal side as much as I do about the physician side. Are they being paid fairly? Are they being supported? Are they burning out at work? Are they frustrated? Those are the things that I'm more interested in so that I can help advocate for them.
So what's in that report that might be interesting to you, and it is a potential shift that maybe we can discuss. So we're going to have this potentially 130,000 physician shortage, but ironically, nurse practitioners and PAs are going to start growing. And so for the audience to appreciate this, I can make a nurse or a PA in 6 years. It takes me 15 plus to make a board certified doctor. So the ability of things to change rapidly is a challenge. And I was looking at the authorities that create the capacity, measure the capacity for physicians. And before I wrote that report, I was very upset saying, these guys are like a union. They're personally keeping the numbers down. And then as I got to the end of it, I started plotting when the baby boomers are all dead. And then you would start realizing if they let it go, they're going to have a whole nother problem in 15 or 20 years with way too many physicians. So I predict, and I'll be curious what you think about this, that one of the things when I interview the nurse practitioners and the physician assistants, is they all say that they don't get to practice to the top of their training. And so my thought is what we may be seeing is physicians given more nurse practitioners and physician assistants, and they become the oversight, they start leading teams versus having to make every decision, and they come and manage the more difficult cases. What do you think about that process, and how would you change your contracts?
Yeah, that's really interesting. I certainly could see that as a path forward. I think I would rebut that with the idea that I think many doctors are feeling as though their work is being encroached on.
Yes.
So I'd be curious, Jim, do you think that trend is one that is helpful for physicians? Is that the right role for physicians, being the overseer of care as opposed to the actual person who's giving the care? I would kind of throw that back and say, is that trend the right trend?
So the encroachment piece was very much related to the CPT code pay by piece, right? And so I think as we move to the value-based system and more people receiving a salary with a bonus, it's going to start measuring on outcomes and value. And I think that, why do you have certain diseases you'd rather go to the Cleveland Clinic versus, Idaho Hospital, which is no disrespect to Idaho Hospital. It's that when you think of a distribution, when we were in statistics, when we were kids, right? The tail of the distribution is when all the madness is. And that experience allows them to look at very complex cases and have insight that other people don't have. So we can have a whole conversation on AI in rural hospitals, and that could change. But I think that physicians aren't having time to, when they're working the little cases, to be able to stay on top of these more complex cases. And so I think there's if they're getting paid for the same and the payment system isn't going to be the impediment, I think there's more joy in the job.
Interesting. That would kind of like mirror like anesthesiologists. Right?
Yes.
They have nurse anesthetists, CRNAs.
Yes.
Yeah, that's a really interesting thought.
Yes. So what would you say is the biggest lesson you've learned thus far in this new journey?
It's not about the money. It's rarely, if ever, about the money for doctors. Doctors are tired. They just want to be doctors. They don't want to be, generally speaking, right? I have doctors who are executives, CMIOs, CEOs. Doctors can be and do anything they want. But the overwhelming majority, the 80% in the middle of that bell curve, just want to be really good doctors and provide really good care to their patients. And the business of medicine is doing everything it can to cut away at that. Fewer resources, see more patients, still very heavily in that fee-for-service world that we've been in as an American healthcare system. And I think for doctors, it's going to take not just one, not just two, but it's going to take a collective to say, we deserve better as a profession. And if we're going to care for people and keep them healthy through pandemics, then we need to be able to be healthy enough to provide that care ourselves.
I think the thing for me that supports that concern is that when I talk to physician friends, because, historically, you certainly have stories as I interview physicians that, their family did something completely different and they became a physician. But a lot of them are from families of nurses and doctors. Mm-hmm. And it's been a thing, right? And so they're advising their kids not to go into it now. And I think that, physicians, by the very nature, are some of the smartest brains that we have in this country. And they can easily apply themselves in other places that make a lot more money. So I've always agreed with exactly what you say. They do it for different motivations. They do it to help people. And I think we need to figure out how to rectify that. And I think, what you're doing here is exceptional and very, very unique. Is there a trade union with what you're doing? Or are you how many people like you are out in the world doing this?
If you Google physician contract review, you'll see a bunch of companies come up, what I call contract review factories, where they'll review it, looks good, sign it. It's kind of like going to urgent care with a broken leg. Mm-hmm. They'll tell you have a broken leg, but they're not going to repair it. I'm the orthopedic surgeon, so I repair it. So right now, I don't know of anyone else who's being a talent agent for doctors in the way that we are. And the main differentiator is that the overwhelming majority of our clients are experienced doctors who feel stuck. They feel as though I'm not able to see my family as much as I like or do things I enjoy outside of work. I never have consistent support in my practice. Those tend to be the doctors we work with. They end up staying with their current employer for better circumstances and inevitably more money because that's how I get paid.
Right.
So unlike the other kind of flat fee contract review companies that kind of churn and burn, I don't work with every doctor. We're not a fit for every doctor. So my success is measured on how much more money are doctors making than their competitors and their partners and competitors.
Very interesting. Good. Anything else you'd like to share with the audience?
I think one thing, if there are physicians who are feeling stuck, I would say talk to your friends. Talk to your friends about it. Talk to your colleagues, your partners about it, because I think a lot of times with doctors, the suffering happens in silence. Or maybe a doctor who gets her salary cut in half will call me and, she's crying on the phone, and that's really unfortunate. But through that, I would say if you are struggling, if you're frustrated, stressed, feeling burned out, talk with your partners and colleagues about it because someone else is probably feeling that too.
Now, how can people get in touch with you?
Our Instagram @Physician Agency is popping all the time. We just started a YouTube channel @The Doctor's Agent. And then on LinkedIn, we've started to share a ton of education on physician contract negotiation and how doctors can be paid fairly. It's just my first name and last name, Nkana, on LinkedIn.
Perfect. We'll have that in the show notes too. Well, thank you for joining us today.
It's been a delight, Jim. Thank you for having me.
Thanks for tuning into the Chalk Talk Gym podcast. For resources, show notes, and ways to get in touch, visit us at chalktalkgym.com.